Diabetes is a disease which occurs among all types of people and in every part of the world. It's believed that in the United Kingdom alone, there are some 250,000 patients under treatment for diabetes, and it's likely that there are at least an equal number of people who have diabetes but are undiagnosed and are unaware of their complaint. Diabetes is an hereditary disease, or to be more precise, perhaps one should say that the tendency to diabetes is hereditary because in many people the disease itself may never become manifest, though the tendency is there and can be detected by special means. In others, actual diabetes develops in middle age, and it comes on very gradually and insidiously, and is often precipitated by overeating. Less frequently, diabetes develops very rapidly and severely, and this is commonest in young people. In young people, the symptoms of diabetes are nearly always severe. There is steadily increasing thirst and polyuria. There's a marked loss of weight and a great weariness. When the urine is examined in these cases, it's found to contain not only sugar, but also large quantities of acetone. Patients in this group, if untreated, soon become drowsy and dehydrated. Vomiting often precipitates coma, and death will certainly ensue unless insulin is administered. Now, studies on this type of patient show that their own pancreas glands are largely incapable of producing any insulin at all. We have modern methods of estimating the amount of circulating insulin in the blood, and in these young patients, no endogenous insulin can be detected. When diabetes begins in middle age, the picture is often quite different from this. To begin with, these patients are usually overweight rather than underweight. Their symptoms are usually quite mild. They may be a bit thirsty. They may be passing more urine than usual. Women often suffer from pruritus. But on the whole, symptoms are not very severe, and quite often the diabetes is discovered purely by chance. Sometimes it's an examination for an insurance policy. Sometimes it's a visit to the doctor for some other reason, and the urine is found to contain sugar on a routine test. When the urine is tested, although it contains sugar, as a rule, there is very little, if any, acetone. If we study these patients by special techniques, we find that their pancreas glands are capable of producing insulin, and in fact there's usually a normal or nearly normal amount of circulating insulin in the blood. Well, if these mild diabetics can produce their own insulin, why have they got diabetes? We believe that these patients can only produce enough insulin under ordinary circumstances. But if they overload themselves by overeating, then their inadequate supplies of insulin break down and up goes the blood sugar. That is why many of these patients can easily be controlled by the simple process of eating less. Is there any essential difference between these two groups of diabetes? That is to say, the young severe one and the older mild one, or are they merely differing in degree? The evidence today suggests that it's really a matter of degree. The deficiency of the pancreas, which is inherited, may vary from a mere inability to deal with a heavy load of carbohydrate in the mild cases to a total absence of insulin production in the severe cases. In fact, there's a sort of spectrum of pancreatic deficiency. And between the severe ones and the milder ones, there's a third group of moderately severe diabetics. Not so severe that they must have administered insulin to survive, nor yet so mild that they can be controlled by simple dietary restriction. And this is the group that we now treat with the new oral hypoglycemic agents, the sulfonylureas, which stimulate the pancreas to produce more endogenous insulin. So, from the viewpoint of treatment today, there are three types of diabetics. First, the severe type, who must be injected with insulin and must follow a regulated diet. Second, a mild group who can be controlled on simple dietary restriction. And third, a group that needs dietary restriction plus tablets. Although we've been talking about mild and severe diabetes, it must be stressed the term mild only refers to symptoms. These so-called mild diabetics, if untreated, if a raised blood sugar level is allowed to persist, these diabetics will develop degenerative complications, arteriosclerosis, retinopathy, neuropathy, and kidney disease. So one must use the term mild with the understanding that it refers to symptoms only and not to the liability to complications. Well, let's now look at the treatment of diabetes today. If we start with a young patient, the underweight patient whose urine shows sugar and acetone, whose symptoms have been severe and who is already dehydrated when first diagnosed, there's no doubt that insulin will be necessary and should be administered straight away if the condition is not to deteriorate. In other patients, there's not the same urgency. And this is particularly true of the overweight patient whose symptoms have been gradual and where the urine contains sugar but no acetone or not much acetone. In these cases, it's wise to start with simple dietary restriction, the diet being chosen according to the degree of overweight. The patient must have explained to him just how important the diet is. He must learn the calorific value of everyday foods, and in particular, which foods are carbohydrates. He'll be given, in fact, a diet sheet, and he'll be encouraged to keep to it and check his weight regularly. He must be taught how to test his urine for sugar, and he must be given the necessary equipment to do this. These patients must be prepared to attend at intervals for blood sugar tests. And as a rule, it becomes apparent very quickly whether or not the patient's diabetes is going to respond to simple dietary restriction. In most cases, particularly if the patient has cooperated in getting down his weight, the urine very quickly becomes free of sugar, perhaps in a few days. The blood tests become normal glycemic, and no other treatment is necessary in these cases. Clearly, not all diabetic patients will respond to dietary restriction, even though they've managed to lose some weight and even though they've been keeping to the rules. These are the patients who continue to show glycosuria and hyperglycemia despite adherence to a diet. And here it is that the new hypoglycemic tablets should be prescribed. The majority of these patients respond extremely well to oral therapy and quickly lose their symptoms and glycosuria. A few fail to respond and will need insulin. In those who respond, the initial dose can often be reduced, provided the diet continues to be observed and the patient is under supervision. Many patients who are taking insulin at present will come to the doctor and say, "I've heard tablets are available for diabetes. Would I be suitable for them?" Well, now, the rules about this are, in general, that any patient who requires more than 30 or 40 units of insulin a day is most unlikely to respond to tablets. Also, the younger the patient, and the longer he's been on insulin, the less likely he is to respond to oral therapy. It cannot be too strongly stressed that no patient, whatever his insulin requirements, no patient should be changed from insulin to the sulfonylurea tablets without careful supervision. Many patients in whom insulin is discontinued quickly develop acidosis and vomiting despite the tablets. The transfer from insulin to the oral hypoglycemic agent is best undertaken in hospital. There it can be very soon established whether the patient can be managed without insulin. More and more diabetics today are being controlled on oral hypoglycemic agents. The advantages of oral therapy as compared to insulin from the viewpoint of convenience are quite obvious. They're particularly marked in the elderly patient, who would otherwise need a district nurse to administer insulin. Although we have reason to be immensely grateful for the discovery of insulin, which has saved hundreds of thousands of lives and is still doing so, yet in recent years we have perhaps become more aware of the disadvantages of insulin. First, there's all the paraphernalia of the syringe and the needle, and the necessity for sterile precautions besides the discomfort of the actual injection. Some diabetics develop local allergic reactions at the site of injections. Others develop lipodystrophy. Insulin is prepared from the pancreatic glands of cattle, and as this is a foreign protein, its injection leads to antibody formation in man. This sometimes partially blocks the effect of injected insulin and leads to instability. This means that some patients are liable to hypoglycemic attacks however careful they are. But over and above all these disadvantages is the undeniable fact that with the best control in the world, in some patients, insulin cannot prevent degenerative changes occurring after 15 or 20 years of diabetes. Even if the patient adheres as carefully as is possible to a measured diet, even then, insulin cannot always prevent the onset of degenerative changes in the eyes, in the kidneys, and in the blood vessels. This is the tragedy that faces all doctors who have to look after diabetic patients. And it is these undoubted disadvantages of insulin that encourages us to view other forms of treatment with an open mind. Now, whether or not the sulfonylureas will be more successful than insulin in preventing the degenerative changes of diabetes in the next decade, well, this is something only time can tell. But in the meantime, we're certainly justified in using this simple and effective treatment in diabetics who respond to it.